morning to all of you. I'm so glad to be participating at this honor to Professor Mascarenhas, and I make the best use of technology on behalf of science and knowledge. And I'm here to talk about the topic of my PhD thesis, which is the formation of the skull as a non-invasive ICP. And we compare that to intraventricular ICP to other methodologies such as skull, brain CT, skull CT, MRIs, and today I'll make a comparison between invasive and non-invasive approach. The goal is to understand the morphology of ICP waveforms. As all clinicians, science may be defined as a systematic skepticism. Our goal is to compare invasive morphology of intraventricular ICP to the wave morphology, to the non-invasive device. Our protocol for 1 year was to assess stroke patients at our service inclusion criteria, patients older than 18 with a stroke and a indication of ICP protocol, and we chose patients with a neurological impairment. Patients, they were monitored invasively and non-invasively simultaneously within 24 hours. And then the brain CT, our catheter was intraventricular one. And we also applied a technology, a wired technology. And that was the monitor where the invasive ICP was performed and the brain for care. And thanks to a software analysis, we could understand the wave form. We used invasive and non-invasive ICP, P1 and P2 relationship, and the ICP time, which is a relationship that reminds us that in case I have compliance in the first peak level, that should be in compliance with, and P2 peak should be longer, changing format and time in relation to the peak, allowing a higher competence to estimate the correlation for invasive pressure and intracranial pressure. Statistic analysis, we have here a correlation considering a qualitative and quantitative analysis. And we also have a rock curve with repeated measures to understand the competence of the wave morphology, invasive and non-invasive. Jamovi, that is a free software that was extremely helpful during the interpretation. During this year, we had 30 eligible patients. 2 of them were ruled out as they did not fulfill the inclusion criteria, and they underwent brain for care, MRI, Doppler, intracranial, CT, considering the wave morphology, a total of 2,500 minutes between invasive to non-invasive, and roughly a total of 200,000 waves. We could see a better performance time to peak between P1 and P2. And as we were measuring the curve between the ventricle and the second one was an extracranial curve, all relationship has a better competence than the rough measure. It's just a matter of sensors distance, and the absolute measure will give us a higher distortion than the relative measure. A reason why P2 in the brain for care was more competent once it was compared to more invasive measures. That necessarily does not have to do with the measure itself, but intraventricular, if I'm right in the middle of the brain, or externally, I'll have something around 5, 7, or 10 centimeters distance, one point to another, been leading to a different cutoff score, reducing correlations and measures, concordance measures. And that correlation still was excellent between P1 and P2. The intra-class relationship was excellent. Kappa was also excellent between P1 and P2 and moderate time to peak. That's exactly why I'm describing relationship and absolute measures. Time to peak is not an appropriated measure, and it's quite common to see changes like that if we are after absolute numbers. And another prediction made by Nicholas in his opening remarks is the intracranial pressure time and the wave morphology and the intracranial dynamic relationship to the brain morphology. How can P1 and P2 waves change right before that cutoff value of 20, which is the ICP cutoff value? We would already estimate that the accuracy of wave morphology, including ICP and brain for care, would not be perfect to estimate ICP, exactly because we do know that wave morphology may be altered even before what we understand by ICP, and that should be also changed if there is ICP present. So those two predictions were made once we assess invasive and non-invasive ICP. And fortunately, I will prove that that's exactly the case. All predictions, they exactly showed that that was the case. And in practical terms, we had the expected outcome.
I think that this is the most important part of the article, even though it was not the main purpose. What does this chart show us? This is P2 over P1 greater than 1. The cutoff was 1.6, very close to other articles, which got a P2 over P1 of 1.5. Line 0 shows patients with no intracranial pressure, and 1 is patients with intracranial pressure. Now, going back here, theoretically, if brain for care is showing intracranial wave morphology for all patients with intracranial pressure, that is going to be P2 over P1, but it does not mean that patient without hypertension won't have that, because sometimes they are in the second part of the curve. Morphology has shown. But the cutoff value of ICP greater than 20 could already be part of patients with an abnormal morphology. Here on the upper portion of the graph, all of patients that had hypertension had P2 greater than P1, but not all patients with normal ICP had normal compliance, because the relation between pressure and compliance follows the rule that we have shown for the relation of P2 over P1. Time to ICP, so one patient going from 0.19, but very close to the fact that for all patients with increased ICP, there is an abnormal TTP, but for patients with normal pressure, we cannot predict that. What does it show us? And that's something that Nicholas mentioned in his question. It applies to screening. So if the patient has P2 over P1, probably there is a good intracranial compliance and good ICP. If the patient has P2 greater than 1 with normal pressure, there is no perfect area over the curve, but showing once again that Brain for Care measures really what is thought to be measuring. The area on the curve of Brain for Care was very close to that, no statistically significant difference. Then P2 and P1 of invasive ICP, and none of them greater than 0.8, because this is how the curve is related. We knew there would patients with P2 greater than P1 without hypertension. And this is why the area of the curve, the area over the curve is so great. And once again, we thought that would be the case. So we were not frustrated with the result. Quite to the contrary, we were very satisfied and happy to understand that we are confirming non-invasively what had been assumed by theories that dates back to 20, 30, or 200 years, reinforcing then the results of theories. Here showing prediction and the results. The cutoff point of P2 over P1 is 1.06, which is perfect in terms of sensitivity and a negative predictive value, and time to peak of 0.19 with lower sensitivity, more specific, also confirming with very high negative predictive value. One of the main purposes of non-invasive methods is screening. If we can select patients, and this is Brain for Care, I'm talking about ED, I'm talking about ICU, we're talking about stroke. But as we've heard before, there is nothing against the use of technology for other situations. But in case of stroke, in a situation of clinical emergency or neurological emergency, have a screening tool to know who deserves invasive clinical monitoring. That's going to be a great advantage to surgeons and intensivists. Now, thinking about the future, how can we expand based on the results from my dissertation thesis and others that had already been conducted? As a group of researchers, considering that treating ICP in randomized trials does not show benefits of invasive monitoring, and one of the criticisms seems that ICP is not an interesting therapeutic target. As a vital sign, it seems to lag behind. It seems to be reactive rather than active. And understanding the brain compliance, now we have the ethical and scientific obligation of creating a project in which we are going to randomize patients to be treated with monitoring of ICP and those monitored by compliance. It had been done not with time to peak, but with wave amplitude by AID and the Scandinavian order. It was published, but he used the wave amplitude using invasive measure, an amplitude greater than 5 millimeters of mercury predicts low compliance, and he randomized part of the patients to be used ICP greater than 20 or wave amplitude, and see the results here. Treating by amplitude below 5 millimeters of mercury, 1/3 of the patients had a rank greater than 2, and only 10% treated with ICP greater than 20 had the beneficial result. So this is a paper that shows us that this can be one more change to paradigm rather than simply wait for a value which is not customized. So 20 is not the number to everyone. And a reactive response, because it's the third phase of the volume over pressure curve. my impression is as if we were waiting for ICP to increase, as if we were treating sepsis based on septic shock. Well, I'm just going to treat the patient when the blood pressure goes down. No, that's differently. We treat sepsis before, because it does have an impact in terms of the outcome of mortality. I think that this is the same level, and that requires a changing paradigm. As we've seen in other papers, there are a number of other parameters in addition to P2 over P1 and TTP to consider to better understand intracranial physiology. Even though we have evolved a lot, there is still a lot being described. So some suggestions on future studies and what variables will have a greater impact on clinical manifestations. These are our two publications. So non-invasive cranial pressure monitoring methods, and finally public, which is the main purpose, a publication in Neurocritical Care Society, confirming, together with the study of other researchers whom we are going to hear from today, we hear about the waveform and the benefit of monitoring, and really how competent this monitoring is for patients who have had a stroke. Thank you very much. Thank you, Fabiano. Excellent presentation. I think the publication in Neuroscience Care has really made a difference. Brazilians being published in a high impact publication really shows the depth and the high quality of the study. During your presentation, a question came to me. How can we bring together the different registers? So QRS, so information from the electrocardiogram, indicating pre-systole, and the repercussion that it has on the morphology of ICP wave. In your opinion, the correlation of the information, not only wave morphology, but heartbeat, depending on the patient's characteristic, whether the patient is an elderly patient, has, let's say, vaso stiffness in itself, it could impact the wave morphology. What is the benefit of having more than pulse pressure, ICG? Is it useful to have non-invasive ICP waveform monitored in patients? What would be the benefit? Well, I think, thank you, Colombari. If we compare ICP and compliance, we really confirm morphology and compliance as vital sign. It becomes like mandatory because it's lost in shock, in severe sepsis, in mechanical ventilation. So expanding the technology and the benefit really expands. What really matters here? Because of the interrelation and what builds this curve, there is not major benefit in just having a snapshot of the brain. And this is why continuous monitoring is so important. You wearing a tie, your P2 is close to 1 just because you are wearing a tie. So it's no use simply observing it now because there is a pressure over your jugular and this makes a difference. But it'd be interesting to observe throughout the whole talk to see if you are breathing well. Of course, I'm just kidding here, but just as an analogy. If we have continuous monitoring of the patient, the initial snapshot might not be so useful. But what I think is going to change is showing the impact on mortality or morbidity. Treating based on compliance will really make a difference. This is going to confirm to everyone, even those who are skeptical. We will show the impact. Good. Brain for Care really measures intracranial waveform. Fine. But what does it mean? This is something that we've been working on our data, but we have to show different outcomes. We can decide if it's going to be hunk, scale, or mortality, because this is going really to convince everyone of the benefit of this intervention. It's a very important step. You see, that paper published in 2011, it indicated that the results were positive, and we have to reproduce that and put an end to our questioning about the effectiveness and the impact it has on outcome. I've monitored severely ill neurology patients and using it and other tools, and it worked great. It's very useful for ICU, for emergency, especially now, which is wireless. Previously, there used to be wired and so on. Now they are not even available. So I am positive that in terms of morphology, and those that have understood the role of morphology, they know that monitoring has to be done. But those which are still questioning its use, we are very close to building science and knowledge to confirm that it's worth using it. That's great. There is one question here which has been sent by the audience. As you were speaking about stroke, what other pathologies can also benefit from the use of technology? Great talk. We are completing a study to be published shortly, and we have this evidence for CT scan, for neural sheath, but there is not the same for SAH, which is not the same for a tumor or for others. This is a very important question. I don't think it's worth to assume that the competence that we observed in our study would be applicable to other disease, especially because we are here trying to obtain evidence for brain for care. So we have to run studies with other pathologies. And I'm saying that because I know there are other groups carrying out studies. External validation for other diseases is important because it applies to all non-invasive methods. Optical nerve sheath is very competent for ICP and also for non-aneurysmatic SAH. For pure SAH, it does not apply. There are 4 papers showing that the accuracy of optic nerve sheath measurement is not good. Transcranial Doppler in turn is good. CT scan is not good for SAH. So this is a very interesting question because it shows that we have to customize for each disease non-invasive metrics, even brain for care. Maybe for ICP time to pick would be better for T1 and 2, for tumor amplitude. I don't know, just coming up with suggestions. I think that we have to keep an open mind to customize to that specific patient and that specific disease different metrics. Nature is very complex, and we shouldn't be afraid of dealing with that. The more coherent we work with the complexity, the more specific we are, the better the care provided, and the more the patient will have positive outcomes. That's great. This is science, isn't it? Never ending. One last question. What is the message you would like to share with physicians who are willing to adopt brain for care for use in hospitals? As scientists, we want other researchers to reproduce results. We want it to happen. There have been publications in Portugal, in Brazil. Things are moving towards that. There is a synchrony of results, which is great. This is what scientists want. So results confirming the findings, different groups confirming the same findings. Brain for care is a real possibility in clinical practice. I really think that Brain for Care at least can be used as a screening tool, and this is the conclusion of the article published in the literature. Let's see, there are 2 cases of TBI, and you don't know which of them needs an invasive ICP. It may cause hemorrhage, displacement, infection. So I don't know which of the severe traumatic brain injuries should undergo an invasive or non-invasive ICP. If you can monitor both with Brain for Care, the one which has greater P2 or a different ratio, I am confident that I would prevent show patients with an abnormal compliance to go into invasive monitoring. We know that volume and pressure and wave morphology will show that the patient which has a better ratio is probably healthier, probably has a better outcome. So for screening purposes in the ICU, I am sure we can use the Brain for Care as a screening tool. Thank you. Thank you very much. It was great to hear you. And this is something very enriching in our morning, talking about this use. So thank you very much. And now we are going to go into the next presentation. Thank you. Great. And a beautiful homage for someone who has changed world science. Thank you.